Good evening. I am presenting you this work about two-step brachiobrachial AV fistula. I come from Aurangabad, and in my hospital, all fistula surgeries are done by myself and my colleague nephrologist. This has been repeatedly said in many presentations. AV fistula is lifeline, but in some patients, conventional options are either not feasible or exhausted, like there are multiple fistula thrombosis, and in those situations, you need some innovative methods. So we describe our case series of brachial AV fistula, that is brachial vein to brachial artery anastomosis. Brachial vein is a deep vein. Normally we create fistula between superficial vein and artery, but this series describes fistulae between deep vein and brachial artery. Brachial vein is a vena comitatus of brachial artery. That means it runs along the course of brachial artery. So this is over the period of last 3.5 years. And all these patients had no possibility of conventional AV fistula surgeries. And we did 12 cases during this period. This represents about 1% of our total work. We have done about 1,000 AV fistula surgeries during this time, included 5 males and 7 females. So as a first step, in this, we take a vertical incision below elbow. Then we expose both brachial artery and brachial vein. Sometimes there is a one brachial vein, or sometimes there are two brachial veins. So vein is identified, mobilized, tied, and cut. And as a next step, end-to-side anastomosis is done with brachial artery. We wait for 4 weeks, and after 4 weeks, we assess with the Doppler. When we observe adequate arterialization of vein, we take the patient for second step. In this second step, we identify the arterialized brachial vein. As I said, brachial vein runs in close proximity or along with brachial artery. You need to separate that vein carefully from the artery. We suture a muscle layer between the vein and artery so that vein comes in the superficial layer, and then the skin is closed with subcuticular sutures. And this is what you want to see at the end of your procedure. So after the second stage surgery, we wait for about 4 weeks. This is the time required for wound healing as well as the local edema which patients develop. So after that, we cannulate the patient in this way. So over this period, as I mentioned, 12 patients, 8 left brachiobrachial and 4 patients right brachiobrachial underwent surgeries. Out of that, 10 patients underwent stage 2 surgeries as planned. 1 patient died within 4 weeks, so he couldn't undergo a second stage surgery. And surprisingly, 1 patient did not require, it was a lean, thin patient. Patient did not require a second stage surgery, and he could be cannulated as such with only after first stage surgery. So out of those 10 patients, 8 patients were successfully cannulated after 8 weeks. It was time period between 8 to 12 weeks. And 2 patients could not be cannulated during that time frame because of the significant limb edema. Limb edema was observed in most of the patients, but it subsided within 4 weeks of second stage surgery. But in 2 patients, it did not subside. And on further evaluation, these patients were found to have central venous stenosis. Of which 1 patient was successfully tackled and subsequently cannulated. So cannulation at time frame of 8 to 12 weeks. So 9 patients were successfully cannulated out of the 12, 8 after second stage surgery, and 1 patient, as I mentioned, after stage 1 surgery. And 3 patients could not be cannulated. Obviously, 1 patient died, so he never underwent second stage surgery. And 2 patients, because of limb edema, could not be cannulated at this time frame. Out of these 2 also, 1 was subsequently intervened, and we were successful in cannulation of that patient. Limb edema after surgery was observed as the most common complication. 9 out of the 12 patients, it was a local edema. And in most of the patients, this limb edema subsided over the period of 2 to 4 weeks after second stage surgery. And 2 patients, it did not subside. Subcutaneous hematoma was observed in 1 patient. It also subsided over the period of 2 to 3 weeks. No limb ischemia or new cardiac events were observed in our subset of patients. These are some of the observations. These are my own personal observation. There is very limited literature on this topic, so there is no guidelines, so to say. But while operating, what I have realized, Brachial vein is a very thin vessel. Like it is a deep vein, we may presume that it is a thick vein compared to superficial veins, but I think vascular surgeons who are operating, they may also second this thought that brachial vein is a very thin vessel and we need to handle it very carefully. It will bleed easily compared to other superficial veins. I prefer to take below elbow anastomosis because after superficialization, it will give me extra 2 to 3 centimeter of length. If I do above elbow anastomosis, that portion will remain, we won't get. If you find a pair of brachial veins, which is common observation, what I have seen is lateral vein is bigger compared to medial vein, and I tend to do anastomosis with lateral vein. And after observing significant limb edema in two of the patients, I feel that we need pre-op assessment of central vein when we consider such position. And unlike brachiobasilic AV fistula, which is transposition fistula, someone earlier presented, which can be done as single stage, I think brachial vein being a very thin vein as a primary vein, I think single stage surgery may not be feasible. So looking at review of literature, there are certain papers which have looked at this type of surgeries. This is publication from 2005 in Journal of Vascular Surgery, and they have looked at two-stage brachial artery similar to our case series. They operated 20 cases over 3 years, and they had a very good success rate of 19 cannulation over the period of 12 weeks. Another study, this study looked at brachial artery, brachial vein, AV fistula versus AV graft in patient with poor superficial venous anatomy, which is generally situation in this patient. So what they observed was this type of fistula had better 1-year patency compared to AV graft. However, cannulation time obviously was more in fistula compared to AV graft. So if you, this study proposed that if you want early cannulation, then graft is better choice. But if you are looking at long-term patency, then in difficult patients, this can be an option. So to conclude, two-stage brachiobrachial AV fistula can be a viable option in desperate situation. We are not recommending it as a first-line procedure. Our success rate in this series appears to be about 75%. There is a limited literature available worldwide. I could only find about 10 to 15 papers. And apparently, I'm sure surgeons have done it, but may not have reported it. This is a first Indian series. Limb edema after surgery is a frequent complication, but which generally subsides over the period of time. And obviously, a small sample size, uncontrolled study, and a single center study is a limitation of this particular observational analysis. Thank you.